Thanks so much for the kind invitation. And this talk I've given many times is an amalgamation of a lot of talks that, honestly, when Greg was at Columbia, we would basically sit, him, Greg, myself, Dr. Moses, and go through every new piece of data that would come out, and the slides would all kind of converge together. So he'll recognize many of the themes, but also some of the slides too. These are all the disclosures that I have from everywhere and anyone. So if you look up on open payments, hopefully you won't see anything else than this. I just like to list it all. But the biggest one is I'm an interventional cardiologist. But I also think another conflict is that I'm a patient-oriented clinician, and that is where this talk comes from. So to just briefly discuss chronic coronary syndromes or stable ischemic heart disease, I think traditionally people have divided up the goals of what you're trying to do when you see a patient in the office into two areas. One is improving symptoms and quality of life. That's often measured by what's pejoratively called soft endpoints, but if you think about it from the patient perspective, it often matters to them more than troponin leaks. And then the second is to improve prognosis. And so the way I've segmented the talk is to first talk about symptoms, and then second to talk about prognosis. There are many studies out there, not just with PCI, but with CABG as well, that we can reduce angina by coronary revascularization. This has been shown in meta-analyses and other ways. But there's also this important facet of what we do when we reduce angina is we can reduce med burden. One of the things I routinely do in clinical practice after a coronary revascularization is I stop patients' medications that are only there for anti-anginal use. And I can tell you honestly that there are many patients who feel better when you stop the beta blocker than actually the incremental benefit of the PCI itself. So that's something I actively do because also I'm a clinician that's honest. I know patients have a hard time taking medicine, so if I want to give them preventative therapies, how much better can it be if I take something else away to make it more palatable to them to add something else? And this has been shown in multiple studies that you can reduce anti-anginal burden through revascularization. In addition, what's important to remember is that not every patient is the same. And so some patients may have a preference to try medical therapy. They don't mind taking medicines. And so if they have minimal symptoms, that's an entirely reasonable approach to take. On the other hand, if they have more frequent symptoms, daily angina, for instance, even in the COURAGE trial, which randomly assigned patients to medical therapy plus PCI versus PCI alone, you started seeing that many of those patients crossed over and subsequently had PCI because the medicines alone were not enough to contain their symptoms. So I think you have to be a good clinician. A lot of symptoms, a lot of disease, proximal disease, that would favor PCI. And if you have minimal symptoms and patients are wanting to take medicines, there's no reason to rush to have a procedure at that time. And this is further validated from the ischemia trial, which showed in those patients that had daily to weekly angina, there was a clear reduction in anginal burden among patients who were randomly assigned to a strategy of cath versus no cath in the setting of a lower burden of anti-anginal use. So why does this come up as a controversy? Why are we talking about it? Well, because there was some controversy. This was back in 2018. Aaron Carroll is a pediatrician who actually wrote this article, "Heart stents are useless for most stable patients. They're still widely used. People are agreeing to an expensive procedure and putting themselves at risk for a placebo effect." So where did this come from? This came from the initial publication of the Orbita trial, which was a really interesting trial in the UK, where patients typically have to wait about 8 months to get into the cath lab if they have anginal symptoms. Something totally doesn't happen in New York. When Rosh Alameh actually randomized these patients to medical therapy, everybody was on medical therapy, about 3 anti-anginals, and then randomly assigned them in the lab to a PCI versus a placebo procedure, there wasn't that great a difference between the two arms. In fact, the PCI arm did improve exercise duration, the placebo arm did not, but the delta was only 20 seconds. Now, many people saw this with a negative p-value and said, therefore, PCI doesn't work, it's just a sham, it's just a placebo, et cetera. I would remind you that even with these differences, if you just double the number of patients that had been enrolled, if they did the study again with twice the number of patients, got this exact same effect size, the p-value would be less than 0.05. But that's not the point. The point is that if you can control patients pretty well on 3 anti-anginal medications, the incremental benefit of a PCI might be less. The question is, do you really want to have those patients on all those medicines, and who were these patients? So first, these are patients with single vessel disease, and 30% of them were physiologically negative. A lot of people criticized the investigators for including patients that had, FFR negative lesions. In clinical practice, this happens all the time. FFR utilization is like well under 30%. So many times this is actually happening. So I think it's totally reasonable to randomize these patients. Remember, these were people who had approximately monthly angina, 1 episode a month, and they were well controlled. So that's the type of patient in whom an incremental benefit of a procedure is going to be a little bit less. They also had good exercise tolerance and minimal ischemia. So if you take patients who are largely asymptomatic, it's going to be hard to show a benefit of PCI in that situation. To credit the Orbit investigators, though, they all then went ahead and did another series of studies, almost experimental studies in a sense, to understand why this was this way and how could we reconcile this with our clinical observations that we can help a lot of people by revascularizing them. So first, they took patients and they, in the cath lab, exercised them before and after a PCI of a physiologically positive lesion. And they got an increment in exercise duration that was a minute. It wasn't 20 seconds anymore, it was a minute. One of the reasons for this is the patients knew that they were revascularized and they didn't hold back in the cath lab. And this was shown by the fact that initially, before they opened the artery, they stopped due to chest pain. But once they opened the artery, nobody stopped due to anginal symptoms. They actually stopped due to physical exhaustion in conjunction with an elevated lactate. So there is a physiologic effect of PCI. They showed this in the subsequent paper, and they went back and analyzed their original Orbita data with a more conventional endpoint, which was Seattle Angina Questionnaire anginal status, and showed that there was a benefit of PCI compared to medical therapy. So I want to credit them because, you know, they could have just sort of done that initial study and just ridden on that and said, this is great, you know, now we've debunked PCI and be done with it. But instead, Rasha especially really focused on trying to understand the effects a little bit better and doing other trials like Orbita 2, which just came out in the New England Journal last year, showing definitively that if you took people off medicines entirely and isolated the effect of PCI versus a placebo procedure, there's a clear effect of PCI in terms of reducing symptom burden. Why do you have to take patients off medicines? Well, because the medicines confound the effect. They dilute the effect, and that this maximizes the signal-to-noise ratio. So where are we left with this? We're left with some guidelines that basically say you should only consider revascularization to improve symptoms after you've failed conventional medical therapy. This is certainly how most medical students get taught now. You have to take nitrates, beta blockers, calcium channel blockers, maybe ranolazine. If people fail that, then you would consider revascularization. But I would argue that you can kind of turn that a little bit on its head because most of those medicines, in fact all of them, don't change your prognosis. None of those medicines, beta blockers, nitrates, calcium channel blockers, or ranolazine affect prognosis. The things that affect prognosis are not on that chart, things like aspirin, statins, and lifestyle modifications. So what I say is if you have somebody with real, true symptoms, and they're willing to undergo a procedure, because that's important, then you can use these medicines to change the disease process and treat their angina most effectively, if you can, with a PCI and do it safely. So that's the symptom part of it. So how do our patients with real symptoms actually feel? They send you notes like this. I thank you for all your help. It's a great feeling to be angina-free, and they're on less medication. But it's also important to remember, especially in the New York area, that there's a fair amount of what I like to call shamuloplasty that goes on, where people get treated and they're told their lives are being saved, and they really didn't even have any symptoms to start off with. And so we do not need to revascularize everybody. And if you leave patients alone such that they don't need it, this is a patient that saw me with a CTO that was asymptomatic, they also send you very nice notes if I just explain to them why they don't need revascularization. What do the guidelines say? The guidelines say that it's class 1A to revascularize patients with symptoms refractory to medical therapy. I think that with Orbita 2 and other studies, you don't necessarily need to have refractory angina, but you want to pick the right patients. You don't want to just take somebody that has GERD and an OM lesion, treat the OM lesion to make yourself feel better, and tell the patient you saved their life. That's not a good way of practicing medicine. So what about prognosis? Can we affect prognosis? If you survey most medical students coming out right now and you ask them in chronic coronary syndromes, is there any prognostic benefit to coronary revascularization? They will uniformly answer, no, there's no prognostic benefit. That's actually probably not true. And it is important before we talk about revascularization to talk about medical therapy. And I'm not going to belabor this point because I know in the morning symposium this was spoken about, but we really, as interventionalists, should be behind interventions that work. What I mean by that is that if you can get a patient to lose weight, get bariatric surgery if they need it, perhaps be on a GLP-1 agonist and lose 20 pounds, that is going to be as effective as an intervention that you do in the cath lab, and you feel good about that just like you feel good about doing a PCI. It turns out we're terrible at doing it. So if we look at patients with established ASCVD that are on high intensity or even any statin, this is horrible how bad we are at doing this. 50% of patients not on a statin with established ASCVD. And I actually think of the cath lab as the ultimate teachable moment. And this was something designed by one of our fellows for a manuscript we wrote, where we typically see a patient that they have non-obstructive disease, and we say we have a 60% blockage in one of your arteries, your outpatient doctor is going to be able to treat that medically. But they're in the cath lab, you're showing them the angiogram. Why would you not say, we have a 60% blockage, your best chance to prevent progression of this plaque, the one I'm pointing to right here, is to reduce your cholesterol down to 70 or even 55. We're going to start a statin today, recheck your cholesterol in a few months to see if you want to adjust your medication. That's the ultimate teachable moment to the patient and their family, and very few physicians do this. We actually started including lipid panels as part of our standard pre-cath lab draw. I know at Mount Sinai this is also done. We wrote this paper stating what should be obvious. This is really basic 101. You're looking at the angiogram. Whether you put in a stent or not, you should be able to do this. Now, beyond that, what about revascularization? Treating and diagnosing severe CAD is prognostically important, especially if you get more severe disease. We look at the COURAGE trial, and this randomly assigned patients to PCI versus medical therapy, and there was not really much of a difference between outcomes. But one of the reasons for that is because these people were basically homogeneous people enrolled in the trial. What we try to do in clinical practice is we try to look at patients that are going to have a good outcome and separate those from those that are going to have a complication or a bad outcome, and really just treat the ones that are going to have a good outcome. So how do we risk stratify patients best? And it turns out the best way to risk stratify patients with stable ischemic heart disease is to know the coronary anatomy. This can be done by CTA. This is data from Denmark, a large series of patients. If you have obstructive disease and more extensive disease on CTA, you have the highest rate of adverse events. Can we modify that by revascularization is the real question, but we also know from old historical studies like the CAS registry that if you're a 65-year-old woman and you have single vessel disease with a 70% lesion, your chance of being alive, her chance of being alive in 5 years is pretty good. But if you have that same 65-year-old woman and she's got 3 vessel disease with a prox LAD lesion, she basically has a 3 in 10 chance of not making it to her 70th birthday. That's important prognostically, and actually we can affect this through coronary revascularization. We have to pick the right patients. This is a really interesting study comparing New York practice with practice in Ontario. Ontario is a socialized healthcare system, kind of like the UK, so you have to have a lot more symptoms and that sort of thing to get to the cath lab. The important part of this slide is that the incidence of left main or 3 vessel disease on a diagnostic cath in Ontario is basically double that of what it here in New York. Why? Because we cath people that don't need to be cathed. We take patients with executive physicals, inferior ischemia, we know it's diaphragmatic attenuation if we're serious about it, we bring them to the cath lab. You're not going to find prognostically important left main or 3 vessel disease if you cath everybody. And that's exactly what happens in a healthcare system like Canada, where it makes it harder to get to the cath lab, and so they're finding a lot more real disease. If you take real disease and revascularize it, you can save lives. This is left main disease. This is for multivessel disease. Many people argue, well, this is done before contemporary medical therapy. Sure, we should maybe redo some of these studies, but that's exactly what happened in the ischemia trial. They redid a study not of revas versus no revascularization, but of cath versus no cath in a more contemporary era. This trial enrolled 5,179 patients. Remember, everybody who could got a CTA up front to exclude left main disease. That was 8% of the population. If you have a busy clinic in Queens, for instance, where there's a high proportion, for instance, of South Asian patients, you could pretty much argue that there's going to be like 1 out of 10 patients that's going to have left main disease in that clinic. So the way I practice is I definitely look at the anatomy and try to do CTAs to make sure I'm ruling out left main disease before I treat people medically. The bottom line results of the ischemia trial are summarized by this. Most people just look at the end of the abstract or the tweet and they say, well, there's no difference between outcomes between these groups. But it turns out that the ischemia trial was actually designed to look at cardiovascular death and MI. It just didn't enroll enough patients to have that as the endpoint. And what you see is very interesting. Up front, there's a risk of going to the cath lab and getting surgery or PCI. But then the curves actually cross and separate to the point where at 4 years, there's actually a statistically significant reduction in cardiovascular death and MI with being randomly assigned to the invasive arm. I would bet that most people in the room, if you're asked to summarize the ischemia trial, do not know that at 4 years, there's actually a statistically significant reduction in cardiovascular death or MI with the Revasc arm, or the cath arm, despite this upfront risk. And so how did this come about, and what is it caused by? Well, it turns out there's actually a reduction in spontaneous myocardial infarction in this trial by going to the cath lab. And that's something that's been seen in prior meta-analyses as well, where you can reduce spontaneous MI. So what kind of MIs are these? Are these type 2s or type 1s? It actually turns out they're type 1 MIs. They're reduced across the board in the arm that goes to the cath lab and gets risk stratification as compared with the arm that never gets the cath. That's actually pretty important. It doesn't mean we have to cath everybody. And certainly we know from the mortality data, people aren't going to drop dead if you don't bring them to the cath lab. But it is important, and the reason it's important is because if you look at what happens in the Bayesian approach at 1, 3, and 5 years, at 1 year there's an upfront risk to coming to the cath lab, and at 3 and 5 years there's actually reduction in the Bayesian analyses, this is in the supplement in the New England Journal, with going to the cath lab. So the reason for this is you're diagnosing and picking up severe prognostically important disease. And the follow-on data from Ischemia Extend supports this. There's a reduction in cardiovascular death that's predominantly observed amongst multivessel disease patients. So this is something that you really need to think about. The reason to do a CTA, the reason to do a cath, is to look for significant prognostically important disease, and in those patients, appropriately make the right decision for those patients. Also important to remember, ischemia didn't enroll the full-powered cohort for death MI. It didn't include patients with ACS or left main disease. EF is obviously an open question because most of these patients had benign EF, and the average angina was monthly. These were largely less symptomatic to asymptomatic patients. I think on the basis of the data I showed you, this is where the guidelines committee made a 2A recommendation in favor of revascularization to reduce cardiovascular events such as spontaneous MI, unplanned urgent revascularizations, and cardiac death. So despite what they teach the medical students, that there's no prognostic benefit, there's actually a guidelines indication to improve prognosis among patients with the most severe forms of disease. I'm about to be done. I just want to make 2 final points. One is on the PREVENT trial. So should we take this even further and start treating vulnerable plaques that are non-flow limiting? The top line results of this trial was that if you took patients and looked with IVUS or other modalities and looked at their anatomy, and you perhaps could improve outcomes because the primary composite endpoint was improved. I'd like to point out from this trial, there's 0 difference in death, one event difference. There's 3 different MI events, and the entire endpoint is driven by ischemia-driven target vessel revascularization, target vessel revascularization. There are additional 21 revascularizations in the medical therapy group. So what does this mean to me? Absolutely, you should not be revascularizing vulnerable plaque, because what the trial shows you is that if you left 803 patients alone, you would only have to treat 21 of them to get the identically same effect if you revascularize 803 patients up front. In other words, you could prevent revascularizing 782 patients by not doing it right away, and there's no harm in terms of death or MI with that strategy. So I've definitely heard interventionalists out there saying this data and saying, now we're going to go change our paradigms and everything. I would say that is not at all how I interpret this when there's no difference in death or myocardial infarction. So what is the role of revascularization? This is something I borrowed from Greg. You have to be a good doctor. If you have severe symptoms, it's going to favor revascularization. If you have reduced exercise capacity on the basis of your lesions, it's going to favor revascularization. If you have ischemia, you don't tolerate your angina well, but you have to be able to tolerate the revascularization and the DAP that comes with it well. If you have vulnerable plaque, it's medical therapy for everybody, and the only reason I would revascularize is if it's flow limiting or if there's symptoms. I'll end with one last slide because this gets debated a lot, and people talk about you all or interventionalists are doing unnecessary procedures just because you want to do it for whatever reason. George Bush was actually asked what he thought about people saying this about his stent procedure, and Ron was dogged enough to ask him, well, what did you think about this when other people were talking about you that way? And I'm not going to make a political comment about what our politicians are like, but he got a lot of flack for all the one-liners he would say at his own expense. That was benign back then compared to what we have now. But the point is he was asked, what did you think? And he said, well, they can say whatever they want. It wasn't their LAD. So the reality is this is a personalized decision. As physicians, we have to be patient advocates, not people advocating for money to the hospital or to themselves. Take the patient's symptoms, their presenting characteristics in hand, and treat the patient for the right reasons, and you'll get the best outcomes. Thanks so much.